this is an exciting 15 minutes, or however much time I have. So let's jump right in. We now know about the microbiome. I want to underscore a few things that have been said but haven't been perhaps said in a succinct way. So the Human Microbiome Project, started by the NIH in 2007, has really exploded. Up here? Better? Got it? Okay. Has really exploded our understanding of what it means to be human, right? So we had about 200 bacteria that had been sequenced at the time. We're now in the second phase of the project, and there are 2,000 bacteria that are now known to infect man, and at least 14,000 that have been identified and are in process of being sequenced. So this is, we are, my first slide here is we are on the brink of a massive shift in clinical medicine, I think. It's an exciting time to practice, and I think we need the tools to start bringing our knowledge of the microbiome into our clinical practice and see how this starts to affect our treatment decisions. Some of the other information that's come out of the Microbiome Project is that we are mostly bacteria, right? What does it mean to be human? We are 10 bacterial cells to every 1 human cell. So this is a really very humbling notion, but it's also important to think about when we're thinking about clinical medicine and what's really making our patients sick. So here's a slide, many things that we've talked about tonight, but let me just highlight again. We have obviously various influences on the microbiome. Certainly where we're born is going to play a very impactful role. Things like age, diet, microbiome certainly does age from infancy all the way up through adulthood. A lot of the choices we make in our lifestyle and healthy living are impacting this. See if this is a pointer. I want to draw your attention though over to here. I think there's an area of medicine that really has an opportunity to make a big difference, and this is in the OB/GYN and pediatric community. There is never a time to jump in and start affecting the microbiome like the babies, and we have work to do, right? I have three boys, no longer babies, 7, 5, and 4, and I delivered my third one early, and he spent time in the NICU, and do you know I had to fight relentlessly to allow them to give me probiotics to that baby, to the point where I ended up having to put them on my nipple to let him nurse off that because they wouldn't allow the supplementation. That's just wrong. All right, there's some newer models that are suggesting that babies that are delivered via C-section should have vaginal secretion swabbed into their mouth to help recreate the microbiome. So these are all wonderful concepts, and we need to start taking the steps. We have the knowledge, we've got to put it into action. So let's jump right into biofilms. So we're talking about the microbiome, but our explosion of understanding has come from the sequencing of the 18 ribosomal subunit, which allows us to extract DNA now from single cells, as opposed to waiting for luminal populations to pass in stool culture. And this is one of the other advances that's occurred in the last several years that's really driven home the point of what we are, what it really means to be human. So the work of Costerden, there's a wonderful paper. He was the father of kind of our understanding of biofilms today. And there's so much work that's been done in this. I certainly don't want to point only to him, but I think he wrote really one of the landmark papers I would encourage you all to take a look at. But the biofilms, of course, 3-dimensional structures consisting of densely packed aggregations. There's a slide to follow that will show you kind of how they form from a planktonic state to adhesion to a solid substrate, and then production of an EPS. Some interesting advances are going to be made, I think, in understanding better what comprises this EPS, some of the naturopathic interventions in the way of enzyme therapy is geared towards the composition of the EPS, which is nucleic acids, protein, lipids. We do a lot of work in our clinic with lipid therapy. We see emulsification of biofilms through this method. You can give bile salts. So there's all sorts of things. Google is an ancient herb that's been used in Ayurvedic medicine for cholesterol management. That's playing a role. So some interesting thoughts here clinically. But the EPS is comprised mostly, the biofilm is comprised mostly of the EPS and a small percentage of bacteria. And even the CDC estimates that we've got nearly 65% of infection today is residing in biofilms. So if we want to successfully treat any infection, we have to really consider this as a model. Here's the slide showing the planktonic state of the bacteria. You've got adhesion to a substrate. Once the EPS is synthesized, this is not easily resolved. Then you've got maturation into more organized forms and polyps. And lastly, you've got breakage of the biofilm and release of the planktonic bacteria once again. So if for any of you interested, quorum sensing is how these biofilms talk. You can do a PubMed search. It's a fascinating subject. There's different enzymes responsible. And interestingly, some of the receptors on these biofilms are sensitive to things like epinephrine, so stress hormones, one of the mechanisms why people may be getting sick when they're under stress. We see in our practice a lot of the children that have post-concussive syndromes. We believe that they're chronically infected, not with pathological bacteria necessarily, but they've sort of maintained a balanced state, and then they have a concussion, and then the infections kind of break out and start to affect them. So this is one of the models that we're looking at. So I put this slide up to emphasize that we are not in a linear model any longer. I mean, I think that's what we all have to take away from this. We are practicing in a three-dimensional world. Koch's postulates, you know, we went through our training and thought that it was the one bug and one disease model, and then of course there's different possibilities for treatment. But I don't think we should think of it this way anymore. We have to think of it in a three-dimensional model, and I talk to my patients every day about balance and what has made them out of balance and how can we get them back into balance. And obviously, gut health is the preeminent theme here this evening, and it is never more important than when you're dealing with a patient that has systemic infection to be thinking always about how to keep their gut healthy. So let's go into autoimmunity, and I want to talk about some fascinating research on vitamin D and the vitamin D receptor. So there's a triad of authors, one out of Cornell, one out of Georgetown, and one in Australia by the name of P.J. Albert, Amy Prohl, and Trevor Marshall. And when I first heard about this work, I had heard about the Marshall Protocol, and I didn't really know all that much about it. But somebody put the idea out there that I should start looking at calcitriol levels in my infected patients, which a lot of my patients are infected, so I'm doing that pretty much all the time. So effectively, this is published in 2009, and there's a sequence of articles that kind of get stronger in their hypotheses. But effectively, you're saying, in this article, is saying the first order model used to guide vitamin D studies is now giving way to a more complex action. The VDR is affecting transcription of at least, in this article it was 913, now it's up over 1,000 genes that impact both calcium and expression of key antimicrobial peptides. So what we're going to say from this, actually I'm going to go back for 1 second. So what I was trained that vitamin D was largely in control of calcium homeostasis. And when you find an elevated calcitriol, you rule out sarcoid, you rule out a parathyroid hormone imbalance. And beyond that, you don't really do that much about it. And you look at the 25-hydroxy, and that's the number that we supplement to, and that most of the research that I've looked at to date had been focused on that. Well, it turns out vitamin D's primary role is regulation of the innate immune system. And it's fascinating. So the VDR is under control of both 25-hydroxy, which is an antagonist, and calcitriol, which is an agonist. So what you have here is a model that's showing in an autocrine manner, when you have activation, localized activation or systemic activation of macrophages and dendritic cells, they possess an enzyme that's the alpha hydroxylase that's capable of turning circulating 25-hydroxy vitamin D into calcitriol, the active form, which then binds the VDR and goes and turns on over 1,000 genes that are responsible for regulation of the innate immune system. This is really profound. That then, the VDR then in turn turns on the enzyme responsible for breaking calcitriol down. So you have a very elegant system. Calcitriol goes up, its production of AMPs or antimicrobial peptides. The local infection or infectious burden goes down, calcitriol comes back to normal, and so on and so forth. The problem comes in when you have dysregulation of the perhaps microbiome, but the infectious load in general, and the pathogens have figured out how to block the VDR. So now what you have is upregulation of calcitriol, but the body's inability to turn on the AMPs, downregulate the infection, and turn off the calcitriol. So This is the initial paper's summary statements were effectively that 25-hydroxy vitamin D is immunosuppressive. It is temporarily alleviating signs and symptoms of chronic disease, but leading to long-term increases in morbidity. Molecular biology suggests that low levels are a result rather than a cause. So what they also go on to say is that the nuclear receptor in the liver that converts oral and sunlight forms of D into 25-hydroxy is also turned off by this process, so you have the inability to convert vitamin D. So for years, I've had patients, that very small subset, but they're there, that you throw large amounts of vitamin D and their vitamin D levels are still 10, 15, 16, whatever, and you're giving them at least 5,000, 10,000 units a day even sometimes. And I really just didn't know what to do with them. So it turned, I believe at this point, we've completely changed their practice model. I no longer give vitamin D in high doses as a result. And I'll talk sort of, as we move through these articles a little bit more about that. But effectively, what this summary was saying is that a microbiota of bacterial pathogens may survive in the human body by secreting proteins that antagonize the VDR and disable the innate immune response. Here's a slide just encapsulating some of calcitriol's effects on the immune system: regulation of Th1, Th2 balance, stimulation of Tregs. Here you have a depiction of the 25-hydroxy vitamin D levels circulating, activation in the dendritic cell, activation in the monocyte over here, and conversion into calcitriol here, and of course then the whole pathway. So fascinating model. Took me at least 5 times through the papers to get the whole thing right the first time I looked at it. But here is more in the sequence. So you've got autoimmune disease in the era of the metagenome. So now we're bringing it into the microbiome, the metagenome, which is a newer term. It's a whole new vernacular out there when we start talking about the microbiome and the metabolome and everything else. And then the next paper is the human microbiome and autoimmunity. So what is this article saying? We can no longer assume that antibodies generated in autoimmune disease are created solely as autoantibodies to human DNA. I mean, that's huge. What they're basically saying is, what is autoimmune disease? We thought it was to humans, but it's probably not. In fact, it probably isn't, but we've got to get there slowly. So autoimmune disease in this article, disease results from a common underlying pathogenesis, the successive accumulation of pathogen into the microbiome over time. I mean, these are profound statements. As you have progressive dysregulation of the microbiome, you have an increasing infectious burden. And what it's basically saying is that autoimmunity is the inevitable fate of the breakdown of the microbiome if we don't start doing things to sort of address this, identify it, correct it, etc. Here are some of the key points taken from this. We've got persistent intraphagocytic pathogens directly alter gene transcription, translation, and DNA repair processes. Throughout life, microbes accumulate into the microbiome and incrementally suppress innate immune defenses. Over time, this may eventually cause a patient to develop a unique cluster of symptoms characteristic of an autoimmune disease. Really amazing stuff. The familial, another interesting concept, the familial microbiome is passed down the maternal line, so there's no gene responsible for autoimmune. This is why they run in families, is because there's maternal passage of the microbiome, and you'll see it linking more to the maternal side, but of course there's mixing of genital flora during intercourse, etc., and so you're going to have the father's genital flora and the father's side reflected as well. Okay, so now we've got molecular mimicry, which we've all heard about, and they're just highlighting the fact between microbial and host proteins causes the body to generate antibodies, become autoantibodies by causing collateral damage. Here we go. Immunosuppressive therapies offer short-term palliation, but immunostimulative therapies improve long-term patient prognosis. I don't have the answers to all this, but I suggest we all start thinking in this way, because this is a massive paradigm shift. And yes, patients with autoimmune flares absolutely need to be helped through those moments and given medications that can help their pain and their inflammation, but we need a long-term plan to get them back under regulation. We do this in our practice with various methodologies. I treat in a very naturopathic model, so we have anything from homeopathics, to herbs, to things like ozone and UVBI, to even IV antibiotics if I have a patient that's sick enough to need it. So here is really the piece de resistance. All of you that are working in the functional model may wonder why there's all this hormonal dysregulation. When calcitriol levels go up high enough, there's promiscuity of the other nuclear receptors. So you're going to see impactful, it's going to impact thyroid hormone, glucocorticoid, and androgen receptors. And so you have this kind of downstream effect of all the hormonal and other nuclear receptor dysregulation. And they, in turn, also promote their own antimicrobial peptides. So you have a secondary effect of a worsening insult to the immune system. So I think these are great papers. This was another taken from Kozłowski and published in 2014. And this is just a little more detail on some of our understanding of how these pathogens are impacting the immune system. We know, of course, Bacteroides to be very favorable, lactobacilli, and of course bifido, which makes a lot of the short-chain fatty acids. But we've got B. fragilis through polysaccharide A and outer membrane vesicles, stimulating the dendritic cells and promoting regulation of the Tregs. So again, you know, as we move through this, you're going to see when we can get the microbiome healthy, particularly in the infant, you're going to see so much less inflammation, so much less disease. And of course that needs to be maintained throughout life with proper diet, etc. Segmented filamentous bacteria, this is an interesting population close to the ileum, implicated in models of rheumatoid arthritis and asthma. One of the ones that, as Dr. Kelman was pointing, there's the same bacteria can be both positive and negative, so some of the literature is mixed. This plays a favorable role, it looks like, in type 1 diabetes, but an unfavorable role in the other two disease states I just mentioned, impacting through epithelial cells, through an IL-23 mechanism, and stimulating Th17 cells. Lactobacilli, through the production of DNA and dipeptides, are making DNA-rich immunosuppressive motifs, which through the dendritic cell is stimulating Tregs. And then the short-chain fatty acids that we all talk about, butyrate, propionate, acetate, dendritic cell pathway, and down to the Tregs. This is a great paper. I put it in here because I tend to come back to it in just about every talk that I give. I do a lot with neurological diseases, and butyrate's playing a very big role in lowering neurological inflammation in some of the patients that we see. We do use it orally often and even intravenously at times, but it's a wonderful paper by Vinolo, in 2011, Regulation of Inflammation by Short-Chain Fatty Acids. So, you know, it's fascinating. This, of course, is made by Bifidobacterium, but here we go, going back to, you know, these are the natural bacteria that we should have in our intestinal tract, and when they're represented in high enough numbers, obviously they're favorably impacting health. So what does all this mean? It means that elevated calcitriol levels are perhaps our most sensitive marker for occult intracellular infection. It's just a suggestion. We've tracked this, as I said, for years in our practice. We probably have thousands at this point that I could tell you before and after calcitriols. So without any intervention now with vitamin D supplementation, if we have a patient that has a vitamin D 25 hydroxy that's normal to low, and a calcitriol that's elevated, I will withhold supplementation until the calcitriol comes down. Now, many times, the interesting thing is that the 25 hydroxy vitamin D spontaneously goes up as the infections clear. So that's sort of telling you in a clinical model how this might all be coming together. And you can treat empirically. It's mostly the intracellular compartment that we're talking about, which is susceptible to bacteria, virus, fungi, etc. So however your practice model is, you can target that with various herbs or however you choose to do it. Should our approach to autoimmune disorders be focused on immune stimulation, regulation instead of suppression? Just a question that I posit. Avoid supplementation with vitamin D3 unless calcitriol levels have been checked. You know, I'm culpable. I was the one putting all the vitamin D at people, so I certainly can tell you that I was in that genre, and we've just changed. It's really only been probably in the last year that we've distinctly changed the practice model. And last but not least, as always, we continue to need research. So thank you.
Thanks so much for watching, and for more great clips like this, please subscribe to our YouTube channel. I've created a special free video just for you. It's called the 5 Steps to Becoming a Leader in Your Wellness Community, and it'll give you some of the starting points on how to position yourself as the leader in your zip code of your health community. All you have to do is click on the link below.